אני מתכבד להזמין לבמה את פרופסור דון גוף, one of the world leading pharmacologists, and we're delighted to have you here today. Please, if you can come, Don. Don was also a clinical director of a clinic for 30 years. It treated many people, worked with many people, conducted very important research. And I also want to graduate you because for the last couple of days, he's been introducing himself as Lisa's husband. But he also is Professor Goff in his own right. So thank you for being with us today.
I'm very happy being Lisa's husband. It's a real honor and a pleasure to be here today. And I really want to thank David and the Israel Rehabilitation Association, the first one, and the Tober Foundation, and everyone has just been so kind and shown us such hospitality. And it's been wonderful watching, in addition to learning about Israel, watching the passion and the dialogue and the fact that people here really do examine the issues, and out of all of the the passion and the struggle and the differences, I think really the truth emerges. So I'm going to be talking today about it's the bigger picture about whether antipsychotics are helpful or harmful or both. And I should say, as David mentioned, my background is I was a clinician and director of a community mental health center for 30 years, and at the same time doing research. And I can say that my research group was very successful at studying side effects of antipsychotic drugs. There are so many, and we made many discoveries about the many side effects of these drugs. Our other aim was to develop better alternatives to antipsychotic drugs, and in 30 years that's been largely a failure, and it's given the problems that these drugs really represent, it's really been a disappointment over the last 30 years. And so I'd say that the advances that we've made in the field in terms of improving the lives of people with these illnesses are really due to advances in rehabilitation and the integration of rehabilitation with medicine. So it's, for me, it's really wonderful to be able to meet with this group, and over the past few days to learn more about current rehabilitation practice and research. These are my disclosures. I can say as in terms of my bias, I am a physician, and I think I bring to this topic probably the more conventional, somewhat conservative standards of evidence for medicine in terms of when we are making recommendations to clinicians and family members. I think we demand sort of a level of certainty which for a lot of this controversy is just not there. It's very unfortunate. So I'm afraid my message will be partly one, that there's no black and white simple answer, that there's such diversity, such heterogeneity between people with these different disease labels that we really can't offer one single solution that will really be correct for everyone. And the other unfortunate fact is we have a lot of information on some of these issues, but I think for the ones that are most controversial, we really lack sufficient evidence to draw a clear conclusion. So for that reason, I'm going to, besides just covering very simple principles about this topic, I'd like to also share some recent research we're doing to give an idea of how complex I think some of these issues are when looked at from a biological perspective, trying to understand what these drugs are doing to the brain. And then I'll finish with one example of a study which I think gives an example of a way we can proceed despite the fact that we may not have all the information that we would like. So to make sure that we all agree on what we're talking about, let me just quickly review, first of all, psychosis. So when we're talking about psychosis, of course, we're talking about delusions, fixed false beliefs that really tend not to respond to sort of standard forms of psychotherapy, or not readily. Hallucinations, usually voices, and disorganization. What's probably most important, though, I think, is to recognize that psychosis exists on a continuum. Many people hear voices. They're not bothered by the voices. Some people find the voices comforting. Other people are tormented by their voices. The voices can increase the risk that they will injure themselves or other people. Psychosis in general can be a fairly mild or moderate condition that people can overcome. They can still be quite functional. For them, it may not be worth subjecting themselves to the side effects of medicine. But it's very important to realize there are other forms of psychosis which really are dangerous. People are terribly distressed. People live with the belief that they may be murdered, that people are trying to hurt them. Some people really develop post-traumatic stress disorder just from their delusional beliefs of the danger that they're in. And it is also, excuse me, quite dangerous. And rates of suicide, rates of violence towards other people. People tend to be victimized who are psychotic. And at least in the US, it's very common for people to end up in the prison system. There are more people with mental illness in prisons than in psychiatric hospitals in the US. So there are really great dangers to failure to treat these conditions effectively. Antipsychotics, I could spend hours giving you data, information about averages and all that. I'm just going to cover simple principles of antipsychotics for people in rehabilitation. It's very clear that they're more effective than placebo for treating acute psychosis and for preventing relapse. Studies have included more than 40,000 patients in randomized, controlled, double-blind trials. The evidence is very strong in this sort of simple level. There's strong evidence that treatment with antipsychotic does reduce violence, violence towards oneself or other people. But it's very important to appreciate that not everyone responds. The degree of response is quite variable. Some people really become symptom-free. Many people continue to suffer from various degrees of residual psychosis. And some people really don't respond at all. Not everyone needs long-term treatment. I'll talk more about that today. And it looks like some treatments that don't involve drugs may be quite effective initially as well. We really don't know with confidence how many people can be successfully treated without drugs, and that's, nor can we really predict who those people will be, but that's a critically important area of research. And finally, the antipsychotics are only treating psychosis. They're not treating the other aspects of schizophrenia, which can be so disabling in terms of, for some people, the illness is accompanied with cognitive deficits and the negative symptoms of apathy and lack of social expressiveness. Very quickly, the antipsychotic side effects, if you work with people who take these drugs, you're very painfully familiar with them. The older drugs in particular, by blocking dopamine, cause neurologic side effects. This picture here is sort of a classic of the tardive dyskinesia, involuntary movements, which can be very stigmatizing, very upsetting, particularly to family members. The older drug in particular also caused Parkinsonian symptoms, tremor, stiffness, slowed movements, apathy that can often be misunderstood for the apathy of the illness, restlessness, and these drugs tranquilize in some ways which can be helpful if someone is overly agitated, in distress, but in the US at least we use the term zombies. People can really lose their spark, their sense of motivation, and it can be really quite unpleasant. The second generation drugs, some of the drugs that really started with clozapine and risperidone, are in fact much better for the neurologic side effects, and even newer drugs still, like aripiprazole or Abilify, are much better as well. But the newer drugs have introduced additional side effects, most important, which are weight gain, diabetes. They increase cardiac risk factors, and we're very, very concerned about these side effects, not only because they can shorten life in terms of obesity and diabetes, but evidence is now really emerging that obesity and diabetes affect the brain, and we really need to avoid these side effects as much as possible. I can just say that when clozapine first came out, because it's the only drug that is clearly more effective, we were so grateful to have a much better agent. This is just a study by a person in my group, Dave Henderson, who was about the first to notice that in our clozapine clinic, in this case at 5 years, 30% of our patients had developed diabetes. It's a very common and worrisome side effect. He then went on with really elegant methods, working with endocrinologists to demonstrate that many of these newer drugs do affect insulin metabolism and can have potentially serious problems. But so put very simply, and along the lines of the diversity, the heterogeneity that we ultimately have to resolve in terms of decisions for individual people, drugs differ dramatically in their side effects. So in the US, we have over 20 drugs available, and so we can somewhat select drugs in a way that for most people we can avoid side effects, but not always. Individuals also really differ in their sensitivity, so we can't predict with confidence which drug will be best for an individual person. Some people actually tolerate these drugs well. Other people, they're just intolerable. So from individual cases where we can't really draw conclusions from individual cases, there's such variety, but to the degree that is possible with this sort of wide range of different drugs, we really need to work at minimizing side effects, and quite often we can, after several different trials, we can dramatically improve the side effects. So this then, in all of medicine, it's a problem to decide whether to treat, what drug to use, and this diagram just shows the typical model in all of medicine, in that individuals decide whether to take medicine, to accept medicine, or once it's been prescribed to actually continue taking it, based on a simple weighing, balancing their perception of benefit versus their perception of the disadvantages, the side effects. And in the case of schizophrenia, this balance is much more complicated. One, because at least initially, many people don't perceive that they have a psychiatric problem. They don't believe that they are delusional. They believe that people actually are trying to kill them. So to perceive benefit from the idea of an antipsychotic sometimes is very, very complicated. And the side effects are so great. And there's often such distrust, I think, of psychiatry, of medical information. It's to help people make this decision can be quite difficult. This is where the entire team, not the physician, but the entire team, rehabilitation, and everyone involved, I think, needs to try to help with this process. We had an anthropologist working with our group once who interviewed all of our patients, and we believed that we were such skilled clinicians that patients were taking their medicine because of our clinical skills and our alliance. This anthropologist revealed and published the fact that actually almost all of the patients said initially they took medicine because of coercion, mostly from families, and sometimes being admitted and being given the message they wouldn't be discharged till they took medicine. After being discharged, after starting medicine, almost all of the people that he spoke to said that over time they would quietly conduct experiments where they would stop the medicine without telling anyone, and often would relapse, and it would take many cycles before people began to perceive benefit from these drugs. Obviously there are many different pathways. So that was sort of the state of antipsychotic drugs, acknowledging they don't work for everyone, but that psychosis is a very dangerous, distressing illness for many people. Despite the high level of side effects, the balance for most people really was in favor of taking these drugs because they clearly are effective. And then Bob Whitaker, who we're very fortunate to have speaking later today, really brought attention to additional concerns. And these concerns, I think that's probably a major point of the conversation today, is despite the fact these drugs are very effective early on and seem to be effective preventing relapse, could they over the long term actually be worsening the course of the illness? And this is kind of a whole new area, and this is really the area where I think we don't have the data from adequate trials to be able to answer. So that's kind of the first half of the story, is are these drugs in some way toxic that we don't fully understand? The other side of the story, and this is a picture of the previous director of the National Institute of Mental Health, and the other side of the story is the belief that early initiation of treatment, which at least in the US is almost always involves antipsychotic drugs, may be improving the long-term course of the illness. So we have this new concern that the drugs are worsening the long-term course of the illness, but a growing conviction that starting treatment very early, almost always with antipsychotics, is improving the long-term course. And so I've been really puzzled by this seemingly contradiction. What really is best for the individual and in terms of protecting the brain? So the idea that early intervention is the best approach really comes from the idea of the duration of untreated psychosis. And many studies have shown quite consistently the shorter the duration of untreated psychosis, so the sooner that antipsychotic drugs are started, not all studies use initiation of antipsychotic drugs, but for the majority of studies have sort of used start of antipsychotic drugs. So the earlier that treatment is started, very often with antipsychotic drugs, the better the long-term outcome. And again, this has launched many initiatives at early intervention, early identification, and early initiation of treatment. One problem with this is we don't know for sure whether the untreated psychosis is the cause of the poor outcome, meaning is untreated psychosis toxic to the brain in a way that treatment, typically antipsychotics, is protecting the brain from psychosis, or is it just that people who have a poor prognosis, who have a more progressive form of the illness, manage to avoid treatment longer? So is their delay a marker for poor prognosis, or is the delay actually representing a toxic process to the brain? Would seem just a fundamentally important issue because it would really determine how we approach treatment. And so far, except with the exception of one sort of quasi-experimental study that suggested that early shortening DUP was improving outcomes, we don't have strong evidence either way. Another interesting aspect of this association is the fact that so this is results of a meta-analysis. Oops, it's up. I couldn't find the screen for a minute. Result of a meta-analysis, and basically it shows that long duration of untreated psychosis predicts poor outcome, but it doesn't predict the person when they first arrive. It's only after, say, 6 months, 12 months, 24 months of treatment that predicts outcome. And I've been puzzled by this as well. If untreated psychosis were toxic to the brain, wouldn't it predict the degree of symptoms when at the time people present with treatment? So this caused us to wonder either duration of untreated psychosis may merely be predicting response to antipsychotic drugs, or along the lines, I think, of some of the concerns raised by Bob Whitaker, could it be that duration of untreated psychosis represents a vulnerability to toxicity of antipsychotic drugs? The longer someone has had psychosis, is the initiation of drugs in some way causing more of a negative effect and worse symptoms? More recently, in the RAISE study, which again was a very important study published a couple years ago, studying the optimal treatment of first episode psychosis, both pharmacology and psychosocial treatments, they found that only the people with shorter duration of untreated psychosis benefited from this new enhanced treatment. So clearly duration of untreated psychosis is very important if it seems to be in some way reducing the effectiveness of our rehabilitation efforts. And I believe we really have to understand the nature of duration of untreated psychosis biologically, if we could understand what duration of untreated psychosis is doing to the brain, so we can protect the brain and try to improve the effectiveness of rehabilitation services. So this is what I'd like to talk next is, I think, what are the key questions, I think, for this conference also is, are antipsychotics toxic over the long term? Are antipsychotics protective? And is psychosis toxic? Very, very important in terms of how we think about early intervention, our use of the drugs. Are we protecting the brain against psychosis with drugs, or with these drugs are we actually injuring the brain? partly in response to Bob Whitaker's important books and the concerns he's raised, with a group of psychiatrists who are, international experts in pharmacology and in the biology of schizophrenia, we tried to sort of review these questions and looking at the literature. And so this is I would refer you to this paper, which was in the American Journal of Psychiatry a couple months ago. It was our best attempt to review all the literature and to see if we could come up with conclusions, because clinicians, people with the illness, their family members are all struggling with how to resolve these seemingly contradictory views. The arguments that we were addressing is one, the fact that clearly the antipsychotics have serious side effects, as I've already mentioned. The arguments, again, by Bob Whitaker and others are that twofold. One is that by the way in which the antipsychotics affect the D2 dopamine receptor, there's a theory, based on animal models, that blocking these receptors over time could cause the receptors to be more sensitive, and therefore people could actually have psychosis or relapse, not because of their underlying illness, but because their receptors have changed over time as a result of these drugs. The other concern is, are these drugs directly toxic to the brain? And there's some evidence of brain volume loss in people who are taking these drugs, and the brain volume loss is greater in people who are taking higher doses of these drugs. And then finally, if these drugs are causing such side effects, and if there is a concern about long-term toxicity, the fact that many people probably don't need these drugs, at least long-term, would really seem to be a problem, and we need to figure out who the people are who don't require them. So those are the serious arguments against these drugs. In favor, one is, again, that psychosis can be very dangerous, very distressing. Just from a humane standpoint, we shouldn't allow people to suffer from psychosis if there are effective and safe treatments. The drugs are, in fact, effective in most people, and there is this possibility that the antipsychotics are actually protecting the brain. So those are the concerns we were trying to weigh. This study just came out after the paper I'm describing, and this is a new longitudinal study looking at the long-term course of schizophrenia. I mention it only because, whereas we used to be told that there was a sort of a deteriorating, a downward course early on in the illness, recent studies are suggesting that people with the illness tend to be stable for the first 5 to 10 years. If you measure their cognitive function, it tends to be pretty stable over the first 10 years. It's only after 10 years that we begin to see more cognitive deficits and more negative symptoms. Most of our models, in fact, our understanding of toxicity is a much shorter framework. We really think in terms of toxicity in the first year or the first 5 years. So I think these new data are going to force us to change our perspective a bit and look further out in the illness to see if we can understand what's happening to the brain at year 10 through 20. So the group that was reviewing all the literature basically concluded that for these concerns about toxicity, there just isn't the data to have a certain answer to it. It would only be by randomly assigning people from the start of the illness long-term, so over 10 years, say, that we could really judge for sure whether it's better to not be treated versus to be treated over long-term. And that's because many of us believe that in some people the illness is progressive, that there is continuing injury to the brain over time, and if we can't randomize people to drug versus placebo, we really can't distinguish whether the drug is causing these worsening in some people versus is the illness progressing on its own. And the kind of studies that we would require currently are not allowed. They're not feasible or ethical, just because most research committees believe it's unethical to withhold effective treatment from people who are psychotic. So that's the dilemma. I think that's why we don't have clear answers and why there's so much controversy. And again, just to repeat what I said, the primary dilemma is we can't draw conclusions from individual cases. From an individual case, we can't generalized to people in general. The problem is if a person has a good prognosis form of the illness, meaning they will do well regardless, they often are able to stop the medicine and will look good, whereas people with the poor prognosis, progressive form of the illness, tend to be prescribed higher doses of the medicine, at least in the US, tend to remain on their medicine because they are perceived as doing poorly. So we really don't know, are people doing well because they stopped the medicine, or were they allowed to stop the medicine and remain off the medicine because they're doing well? If a person is losing brain volume on scans and taking a higher dose of medicine, is it the higher dose of the medicine that's causing the brain volume loss, or because they have poor prognosis illness with brain loss, is that why the clinicians are prescribing higher doses? And by our review, we just concluded the information available didn't allow us to tease that out. So given, and obviously this is a very complicated story, I would refer you to the paper and then obviously to Bob Whitaker's books. Fortunately, you'll hear from Bob, I think, a very different sort of view of the data later today. But in general, in terms of what can we say, one is psychosis is clearly very risky for many people. The drugs are clearly effective by our usual standards, placebo-controlled trials. Side effects are very problematic, vary between people, but can be quite problematic, both in terms of their psychological well-being, but also in terms of weight gain and new forms of medical problems resulting from taking these drugs. Whether psychosis is toxic to the brain or whether antipsychotics are toxic to the brain, we need to be aware of these risks, but we're not able to tell with any certainty based on the existing evidence. And it's by looking at the pattern of relapse in relationship to stopping drugs abruptly or tapering drugs, we just didn't find clear evidence that the drugs were in fact promoting relapse through dopamine supersensitivity. That's not to say that that doesn't exist, but at least the existing data at a level that would meet standard medical threshold of evidence, we just couldn't draw that conclusion. So that's I'm sure a pretty unsatisfactory review, but I think it's at a time when family members are sort of desperate, and I think there are people who are deciding not to take the medicine and endangering themselves, and the intent is to give people, I think, permission that, look, we really don't know for certainty, be aware of these risks, but we really have to individualize treatment based on each person's relative vulnerabilities. So let me then I want to try to shed a little bit more light on this process. And so just a quick bit of neuroscience. This may be mostly for the balcony up there. So the question is, we really need to understand, I think, toxicity to the brain. We need some way of predicting, some way of measuring, some way of understanding, is the drug injuring the brain, is psychosis injuring the brain, do people differ in this way? So we decided to study the hippocampus. The hippocampus is Greek for a seahorse. It is here on your left. And it's a sort of a primitive part of the brain, but it's, we think, the best place to look in the brain, in that volume change in the hippocampus is most prominent in schizophrenia. It's the part of the brain that's most sensitive to stress and to the sorts of toxicities that we think psychosis or drugs might be producing. And hippocampus, we think, is sort of driving their early psychosis, and loss of hippocampal volume is the best predictor of outcome. So we decided to just look at the hippocampus. The question is, we can't study people off of drugs. We're not allowed to withhold treatment from them. But if we looked at people during their first 8 weeks of treatment and looked at whether the hippocampus is decreasing in volume, could we sort of perceive whether the duration of untreated psychosis is affecting that process, that measure of toxicity? And I'm not going to go into any detail, just share with you the results. So this figure shows the hippocampal volume. Blue is in healthy controls who are matched to our patients in terms of age and gender. Red are people with non-affective first episode psychosis, with schizophrenia who have never been exposed to treatment before. And so when they first arrived and started treatment, people with schizophrenia had very significantly reduced size of their hippocampus. Then these lines show the change over 8 weeks. And as you can see, over just 8 weeks, we were able to detect a very dramatic loss of hippocampal volume during the first 8 weeks of antipsychotic drug treatment. If this 8-week trend were to continue for a year, it would represent a 6% loss of hippocampal volume, really quite striking. So when I first saw these results, I thought, oh, absolutely, drugs are toxic. Absolutely, the drugs are associated with this 6% annualized rate of hippocampal volume loss. And I'm doing this sort of in an exercise, I think, to show how difficult it is to draw conclusions. However, we then, just out of curiosity, drew lines, and these lines go back to the onset of psychosis. So these are averages for these groups. So if we draw the line back to the average time when psychosis started, you can see that this rather dramatic loss of hippocampal volume, if it had started at the beginning of psychosis, which a lot of people think is the case, it could be accounted for as part of the psychosis, so that psychosis could be causing hippocampal volume loss, which continues during the first 8 weeks of antipsychotic treatment. The reason we chose 8 weeks, by the way, is that antipsychotic drugs do not reduce the dopamine release, which we think is the toxic part of the drug, toxic part of psychosis. They don't really stop that until after 8 weeks. And in general, psychosis tends not to resolve until after 4 to 8 weeks. So it may just be that we're seeing the loss of hippocampal volume associated with the illness. And it turns out when we look at biomarkers and the genetics, it's more indicative of this being a psychosis-related effect rather than a drug-related effect. We then got another sample of 100 first episode patients who we started imaging after 8 weeks, and we followed for 1 year. And the reason is, this is interesting, but it's only 8 weeks. Is it really relevant longer during the course? We found that over the next year, there was essentially no additional loss of hippocampal volume. So, we can't draw a conclusion, but it's consistent with the idea that the drugs require, say, 8 weeks and in some way are protecting the volume of the hippocampus for those 8 weeks. I would love to see this for, say, soteria or for open dialogue for other treatments not involving antipsychotics, if by stopping psychosis we could affect the same change. And most importantly, we found that this rate of loss of hippocampus highly correlates with the duration of untreated psychosis. For reasons that aren't clear, the longer that psychosis persists, the more rapid the loss of hippocampal volume. So, we could almost stop there, but then I think, as in all, almost every story in this area, it gets progressively more complicated. This shows the individual patients, the rate of the hippocampal volume loss, and on the x-axis is their duration of untreated psychosis. And I think what's important is it's often misleading if we look at averages, for patients and controls. So when we look at the individual patients, at least to my eye, there are three groups. One is there's one group, and this is almost 2/3 of the patients, don't seem to be having any change in hippocampal volume. They start at a level that's pretty close to normal, and we don't see any effect, so no suggestion of effect of either psychosis or drugs on their hippocampal volume. The second group is a group that has data really consistent with a loss of hippocampal volume that started at the onset of psychosis and is continuing. And then the two patients, again, I obviously didn't mention this this work will be published in JAMA Psychiatry shortly, but I didn't even mention this in the paper because we're not allowed to draw conclusions from two subjects. But there were two subjects who started with essentially normal hippocampal volume, and then they actually lost the most volume during the 8 weeks of treatment. So, we don't know, and I'm not presenting this as in any way a fact, but as an example of how complicated it could be. I think the lesson here is there may in fact be subgroups of people, some of whom are not having injury to their brain from psychosis or from drugs. Some may be having injury from the illness, and fortunately a smaller number that may in fact have injury from the drugs. Okay, and that's essentially what these two slides say. So let me then finish, and that is partly, in apology for the fact that I realize I've not been able to say anything definitive, and the question is, I think it's very important that for shared decision making we actually have irrefutable, solid evidence for people in terms of what is the true risk over time of taking these drugs. I think we're actually doing people a disservice to tell them that these drugs are going to worsen long-term course. I don't think we know that for certainty. I think we don't know for certainty that early intervention is more effective for everyone, but we need to figure out what to do in the interim. So the one study which I think is very important, I think many people think is important, is the so-called Wonderink study. So Wonderink was the first author of this Danish study. And in this study, they took people with the first episode of psychosis after they were stabilized for 1 year. So these are people who responded to medicine for 1 year. They then assigned half of them randomly to treatment as usual. They made no changes in their treatment. The other half, they made a very careful attempt to taper and stop the medicine. And they did this so carefully that during the course of this study, 18-month study, even though there were many relapses, not a single person ended up in the hospital. So they were watching them so carefully. At the first sign of relapse, people were restarted on their medicine and their medicine was adjusted. So the first report of this study, which you see here, was published in sort of a third-tier journal. So this study did not draw much attention, and the reason was that this careful attempt to discontinue drug and to lower the dose of drug ended up triggering an unacceptable rate of relapse. And the relapse rate was about 40% versus 20% in people who just stayed on their regular drugs. So this was sort of nothing new. We all expect that attempts, unfortunately, to discontinue medicine are often accompanied by relapse. And I think that's why, even though we often recommend that people try this, I think because relapse is so common, it's not often done. What's important here is they managed to avoid any protracted relapse. And there are no relapses that, say, in my experience, I've had people where I've tried to do this, they suddenly become psychotic, they then refuse further treatment, and sometimes they'll go a year or two off of medicine, psychotic, and can be really unfortunate results. That didn't happen this day. They did a wonderful job discontinuing. What was important was after the study had ended, they then 5 years later returned to look at how patients were doing 5 years later. So they were no longer specifying the treatment, but they just want to see what's the 5-year consequence of people for whom we managed to take off of medicine or managed to lower the dose. And it turns out about 20% of these people were able to get off of medicine. The dose on average was decreased, but not very much, from about 3.5 to 2 milligrams of risperidone. So fairly modest dose reduction. A fairly modest percent of people managed to get off of the drugs. But remarkably, 5 years later, the relapse rates were the same. So the group that was now getting treatment as usual continued to relapse. The people who had carefully been titrated remained stable and didn't relapse. And the people who had been in this experimental condition of lowering the dose, trying to get people off the medicine, actually were more functional. So their symptoms were the same, but 5 years later, their level of function was substantially higher than the other group. So this is, I think, important study. The problem is we're not sure why this group did so well. In terms of so first, just to repeat, so about 20% probably don't require long-term medication if we were to draw conclusions from this study. And attempts at medication discontinuation, if done very, very carefully, only produced very brief relapses followed by stability and better long-term outcome. So I think the standard interpretation is that if we can get people off medicine, although a very small percentage, and lower their doses, that they will do much better. I just want to also raise the possibility, and that is, not only do some of us believe that untreated psychosis injures the brain, early in treatment, prior to starting treatment, there's also some evidence that relapse may injure the brain. And another possible interpretation of this is that by lowering the dose and stopping the drug, avoiding long-term relapse, they managed to, I think, number one, arrive at the best possible dose for people, identify those people who could safely remain off the drug, and I think they probably really strengthened the alliance with people, that people had their chance to try to get off the drug and probably at that point were willing to remain on drugs. The other group who relapsed were no longer in the study, and probably their relapses were much longer. They were not being watched carefully. So there's possibility also that their relapses were more toxic to the brain. And so this may also be an example of relapses occurring without this very careful, immediate resumption of treatment may also account for this. And and these relapses may have been, again, this fact that if someone has been put on a drug, never been allowed the chance to get off, they may experimentally try stopping their drugs and relapse as a result. So I think this study, although we don't know for sure why it was so more successful, at least gives us one example of how we can proceed in an individualized way until the necessary studies might help us understand this. So to summarize, again, very important that not in everyone, but in some people, psychosis can be distressing, dangerous, and disabling. We need to, I think, really view it that way in terms of safety and sort of humane relief of suffering to provide some form of treatment that will help and keep people safe. It's clear that the drugs are more safe or more effective from our standard methods of evaluation using placebo, but not everyone needs antipsychotic, possibly initially, nor does everyone need it long term. We need to learn how to identify those who don't need it and hopefully come up with other treatments other than antipsychotics. There may be a risk that protracted psychosis, either delayed to treatment or relapse during treatment, may injure the brain in some people, so we need to avoid that most likely. And whether antipsychotics on their own are worsening the long-term course or making people more vulnerable to relapse, I think we don't know for sure, but again, we need to study that, and people need to be aware of that as well, of that possibility, but not certainty when they make decisions. And finally, until biomarkers are developed, like the one we are working on to guide personalized medicine, I think this last study by Wonderlink is probably the most promising approach. But again, doing it very carefully so we don't get more serious relapses. And early intervention with novel treatments other than antipsychotics, I think, is our eventual goal, so we can avoid this controversy altogether. And these are my collaborators on these various studies. How much time do I have? Am I done? Okay, good. Thank you.